Good morning, everybody. Thank you for spending your Saturday morning with me. It's much appreciated. I'm Kemi Nurudeen, Director of Fertility Preservation here at HFI. This talk is an excellent option for patients who are considering egg freezing. You know, before you leave today, my goal is that you gain some knowledge about your fertility and learn a little bit about the option to freeze your eggs, and also decide if egg freezing is the right choice for you. I feel that by educating women about the facts and science behind egg freezing, it empowers them to take control over their future reproductive options. So hopefully this talk will be helpful. All right. So what is egg freezing? We're going to go through basically the definition of egg freezing. So we have some old terms that we used to use, like social egg freezing or elective egg freezing, when egg freezing was basically deemed non-experimental, which we'll talk more about a little bit later. The current definition of egg freezing is preserving your reproductive potential in women of reproductive age. So these are women who are freezing eggs without fertilizing them. Obviously, they may or may not have a partner, but the eggs are being frozen at the egg stage before fertilizing with sperm. We actually prefer the term planned oocyte cryopreservation. The 2018 ASRM Ethics Committee actually introduced the new term planned oocyte cryopreservation to avoid trivializing the process of egg freezing. By calling it elective or social, they didn't want to put a stigma on the process and actually think of it more as a legitimate medical procedure. So we try to avoid terms like elective egg freezing and social egg freezing and focus more on the new term, planned oocyte cryopreservation. So now we'll review the history of egg freezing and the history of the development of the technology to do oocyte cryopreservation. We will also briefly discuss the difference between the traditional methods. The first human birth, so we have a lot of history in our field that was more recent, the 70s, 80s, a lot of things happened in our field. But the first human birth from a frozen sperm, so we've been freezing sperm a lot longer. Frozen sperm first had a first pregnancy in 1953. Our first pregnancy from IVF, as you can see, was Louise Brown in 1978. And then in 1981, we had our first pregnancy from IVF here in the US, Elizabeth Carr. Our first pregnancy from an embryo was in 1984. And then our first pregnancy from a frozen egg was in 1986. So after 1986, we kind of had a little bit of a break before we went back to egg freezing. And there was kind of a break, a lot has to do with the technology available then. Egg freezing just wasn't as efficient as sperm or embryos, and we'll talk about why. So the eggs were initially challenging to freeze, and the reason why there was this break in the 80s, because if you think of a sperm and the egg is a bigger cell. It has a lot more water content than the sperm. So when we would freeze our eggs, just like if you were to freeze a glass of water, you get crystals and ice forms inside in the water. When we freeze eggs, they're at a certain stage of the DNA development that when you would freeze them at that point, the ice crystals would damage the spindles that hold the chromosomes in place. So we were looking at a lot of damage to eggs. So we tried freezing very slowly in order to avoid having that crystal damage. And that was successful for a while, but we started to introduce something called vitrification. And vitrification is when we went from slow freezing to rapid freezing. So ultra rapid freezing would freeze the eggs in a glass-like slate, and we would avoid the crystal formation that we were dealing with slow freezing. So when we were reintroduced to egg freezing, the revival at that time, I think in 1994, we were still doing the slow freezing, but in 2007, 2008, we started doing more vitrification, and we started seeing a lot more successful outcomes with egg freezing. A few years later, 2013, ASRM actually lifted the label of egg freezing as being experimental. So now they thought of it more as a legitimate process or protocol treatment that we can do in our field where it's not labeled experimental. And a lot of it had to do with the advancements that we made with vitrification. So that basically wanted to, when we put that guideline out, I think I was just finishing my fellowship at Columbia. So I remember at the time starting my job at HFI, and I wanted to be director of fertility preservation because I knew this new document was very timely. We knew that this was something that was going to become more available, more available and more widespread, especially with the experimental label being lifted. So with vitrification, we're seeing excellent survival rates and developmental ability of your eggs. It's the most efficient approach to egg freezing, and it's now considered standard of care. So why is it important? With the introduction of the birth control pill back in the 60s, it made a big impact in delaying childbearing. So women have access to being able to control the time they want to get pregnant. So we were starting to see families change. We're seeing the focus. Our current social setting is that we focus on small families. There's a change in the role of children from the 60s, obviously, even before the 40s, 60s till now. Children are less seen as economic advantage or labor support for parents, obviously. We're a little focused on smaller families. Women are more into their careers, and they have more availability of the birth control pill to help control getting pregnant. So because of not only because of effective contraception, delayed childbearing is also occurring for a number of reasons. Lack of a partner. Some patients are in a relationship and are looking to get out of that relationship and want to have the option of reproducing with a future partner. We have to think about educational and career pursuits that women are pursuing. We are not only seeing this in the US. There was a study in 2011, an international study that looked at delayed childbearing per country. And that review of published data actually saw the postponement of childbearing increasing in different countries. I think Europe and Japan, usually the first birth back in 1970 was 25, and then they said in 2008 it increased to 29 for the first birth. I think Iceland had the highest increase, a 5-year change in the first birth, and the US was actually what we would call the youngest country. We saw a change from age 21 in the 1970 to 26 in 2014 for our first child born to women. So the trend in later motherhood can cause a reproductive dilemma as women, as what we call the expected age, we have an expected age of pregnancy. We still see a decline in the egg quality and egg number. So it's important to consider egg freezing given the changes and the delayed childbearing that we're seeing. So female fertility decline, as our reproductive lifespan is finite. So we're born with all the eggs we're ever gonna have. By the time we get to puberty, we probably have 300,000 to 400,000 eggs. Those 300,000 to 400,000 eggs a lot of them are going to be wasted. In our lifetime, we only are going to ovulate 300 to 400 eggs. So every month you ovulate 1 egg, and every month you bring a certain number of eggs to the starting line. So when you start your period on day 1, you bring a certain number of eggs out of your total pool that you're born with. Out of that recruited bunch, only 1 gets selected and the rest basically die off. As we get older, the numbers start to decline. More significantly at age 37, and then we start to see really big changes in numbers and quality in our late 30s, early 40s. So also there can be other reasons women may need to consider or may have a risk for fertility decline, not only because of the natural fertility decline that happens, but some women who are exposed to chemoradiation, some women who've had multiple surgeries on their ovaries may be at risk for lower egg count. So it's important as a reproductive endocrinologist, when the patient comes to see me with a history of even endometriosis or a history of cancer treatment, that we talk to them about the option of egg freezing. And what ideally it'd be nice to do with egg freezing before getting chemotherapy, but it's not always the case. A lot of oncologists are working hard to try to refer patients before starting chemotherapy regimens, which can be very helpful. Also, some women may be at risk for early menopause because of a genetic condition. There are conditions like Fragile X premutations that women are born with that puts them at risk for early menopause. And even women who have something called Turner syndrome, where they have a missing X chromosome, that also puts them at risk for early menopause. So there are medical indications, and then we have the natural fertility decline that happens in women as they get into their mid to late 30s. So In this picture, you can see many celebrities are showing pregnancies at various ages, and there are various reasons why they're conceiving. You know, not many celebrities are very open about their experience for pregnancy. Some of these celebrities may have had the opportunity to freeze eggs and when the technology was changing to vitrification, or even when it was slow freezing, because we still had pregnancies from slow freezing in 1994. So we really don't know the story. Some of these women may be using donor egg, but I think the frustrating part sometimes is, you know, I think the media can sometimes make it seem that pregnancy at different ages, a natural pregnancy at different ages can be easy to achieve. And I think it's good for patients to be educated early on what the natural fertility decline is and what their options are at different ages, whether they freeze eggs or choose not to freeze eggs. So why do women seek egg freezing? We kind of talked about it a little bit. Not having a partner, professional, social, financial reasons, health reasons, like we mentioned, diminished ovarian reserve. We do feel the egg quality is better in your late 20s, early 30s, but there's still opportunities for patients to consider egg freezing later in life. We also have to consider even ethical reasons, religious reasons, legal reasons. So ethical reasons, we have couples that go through IVF and they have an idea of the family size that they want to have. And in some conditions, some patients may not want to have a lot of embryos stored to have to make a decision on in the future. So we may talk to patients about partially freezing eggs and partially fertilizing the eggs. So if they decide that, you know, we are done with our family, it's easier for us emotionally, ethically, and for religious reasons to discard eggs than embryos, then we'll talk to them about not fertilizing all their eggs, and they may go through an egg freezing process. So egg freezing, like I said, is kind of fertility insurance for a lot of patients who either have medical or educational career pursuits to give them a reason to freeze eggs. So who is a candidate for egg freezing? So we say a lot of women are candidates. We try to get patients to do it as soon as possible. I always tell patients, if you can get it done in your 30s, 20s, 30s, it's nice to consider it during that time. We understand it's not always affordable. So I think having patients doing egg freezing in their 20s is a little bit rare, and then we understand because of financial reasons. But if a patient wants to be proactive and at least find out their fertility status and keep on top of it with us, we can always look at the ovarian reserve testing and get into if we get to a point where we feel like, you know, maybe we should consider egg freezing before these numbers get too low, we can actually counsel patients. So ideally we have a time frame, but we also know we can walk our patients through just being monitored before they're ready to egg freezing. And they may not be ready for financial reasons or even just emotional reasons. So it's quite understandable. So what is the process? We're going to talk a little bit more about the details of egg freezing. So like I said, you'll have the initial consult with one of the HFI doctors. We'll sit and talk to you about your medical history, your surgical history, any medications you're taking. Social history is important. We want to know if you have any tobacco exposure, using smoking cigarettes, alcohol intake, caffeine intake. And for some patients, we want to rule out any history of any chemical exposures. Sometimes some people are working in plants or areas of Houston where they may have some exposures that concern them. We do a physical exam. We do blood work and an ultrasound. So the timing for the evaluation is best done at the beginning of your cycle. So what we have you do is the first day of your period, which is called day 1. We have you call our office on day 1. You'll come in between day 2, day 3, and you'll start with your blood work. There are a couple of big blood tests that we care about when it comes to ovarian reserve. So the first one is Anti-Malarian Hormone, or AMH. This is a hormone that comes from your ovaries. The more eggs you have, the higher that hormone. So that hormone can be checked actually at any point of your cycle, but gives us a good idea of where your ovarian reserve is. It's a good predictor of how you would respond to the medication that we give and the number of eggs that we can achieve. The other hormone, which we recommend is done between day 2 and day 3, is FSH, follicle stimulating hormone. So that actually comes from your brain. It comes from your pituitary. It's a hormone that from your brain, it talks to your ovary. So if your egg count is low, your brain starts to work harder to get your eggs to respond. So if your FSH starts to go up, it means your brain is working really hard because the egg count is low. So between the FSH and the AMH, we can get a clear idea of where your ovarian reserve stands. The other thing we like to do on that day, the day 2, day 3 of your cycle, we like to do an ultrasound where we actually go through and count the follicles on your ovary. So like I mentioned earlier, we do see a recruitment of follicles, eggs, every month at the beginning of your cycle, and your brain only picks one. So when we do that ultrasound, we actually count the follicles because a number between 7 and 10 is considered what we consider normal. And sometimes if we see a lower number than expected, it can also help us predict your response to a number of eggs we could achieve with egg freezing, similar to the AMH test. So after you've completed your testing, you'll do a follow-up with your doctor. And for women who are egg freezing, that's kind of where things stop. It's a day of blood work and ultrasound. And then you'll see your doctor probably about 2 weeks later to go over the results. Now, one thing I will bring up, because your doctor will talk to you about this, if you want to do genetic carrier screening for diseases like sickle cell disease, cystic fibrosis, to see if you're a carrier now before obviously fertilizing your eggs with sperm, it's important to consider as well. There are patients who are carriers for diseases that when they meet their future partner or are using sperm that may belong to a man that's a carrier, it's important that they know their own status and if their partner or sperm donor status needs to be checked. So we will offer that as well, especially if you know you have a family history of a genetic disease. Now, sometimes these diseases are not, they're not going to show in your family, and you might find yourself to be a carrier. So your doctor will talk to you about that in more detail. Once your testing's done, then we'll talk about the process of egg freezing. So that one cycle we use for testing, for some patients, they can actually the next cycle start thinking about the process of egg freezing. And I'll try to keep it really simple. When you start your period, the day 1 of your cycle, usually 14 days later or 2 weeks later, you are going to ovulate that one egg we talked about from the recruited ones that you had. So the beginning of the month, you have that pool of eggs, one gets selected 2 weeks later. When you do egg freezing, during that 2 weeks, we give you the IVF injection hormones to get all of those eggs to grow. So our goal is to overcome the one follicle your brain will select by giving you the same hormones. So we give you hormones in the form of FSH, which comes from your brain, and LH that can actually stimulate your ovaries to make all of those follicles make it 2 weeks later. So you can see in this picture in the middle, the ovarian stimulation after 10 to 14 days. All of these are all good-sized follicles that each contain an egg. So that's the kind of ovary we want to see after 2 weeks of stimulation. Now, if you had not done the medication we gave you, it would have just been one of those circles at the 2 weeks later that your brain would have picked, one egg for the month, okay? And the rest of those would have been lost. So when you're doing egg freezing, don't think that you're depleting your egg count. You're just recruiting what your body would have lost that month anyway. So just keep in mind, I'm just recruiting what my body would have lost. If I hadn't done these medicines, I would have picked one of these follicles and the rest would be gone. And next month, another batch would come, okay? Once we get to that size that we see here in this ultrasound picture, that's when we trigger you to go for your egg retrieval. So we give 2 options for medications to help release your eggs. The first one is Ovidrel, or HCG. So it's very similar to the LH hormone that helps release your eggs naturally. So the HCG is given, and 34 hours later, we will schedule you for your egg retrieval at our Piney Point office. Now, there are other triggers for patients who have a big response, like an AMH that's over 3 or 4. So these women are at risk for ovarian hyperstimulation. And someone asked me a question, so we'll talk a little bit about that. Ovarian hyperstimulation, there's a lot of risk depending on your testing. So that testing you have with your doctor, you'll meet with your doctor and they will go over not only the number of eggs you can expect to achieve, but also your risk of hyperstimulation. And hyperstimulation is basically women who take the medications, they respond robustly to the point where, yes, they may be getting 20, 30 plus eggs, but they also are dealing with bloating. They are dealing with a little bit of nausea. When you're hyperstimulated, your blood vessels sometimes start to lose water into your pelvis. So women will be a little bit bloated at the time of the retrieval. That can last about a week or 2 later after the retrieval. So most women after their retrieval will have their period 2 weeks later. So your cycle just resets. By the time you have that period, your bloating will be almost back to normal in most cases. Now, we have a trigger medicine. I talked to you about the HCG, but we have another trigger medicine called Lupron that will help curb those symptoms really quickly. So a lot of women who get the Lupron trigger will have their cycle really quickly. It won't be 2 weeks. Some of these women, it can be 1 week. But this can also temper the risk of hyperstimulation. Now, Lupron trigger patients get the same timing. 34 hours later, they're going for an egg retrieval. Now, in egg retrieval, the process of retrieving eggs is actually through a transvaginal approach. There's no cutting on your tummy. There's no surgery on your tummy. Everything is through the vagina. So if you look at this picture here, I know it may be hard to see, but the ultrasound probe, if you've ever had a vaginal ultrasound, goes into the vagina and stops at the level of the cervix. The needle that we use to aspirate the follicles is attached to the ultrasound probe, and it goes directly to your ovaries. So your ovaries don't sit out next to your uterus, sitting really high and straight. They actually sit lower in your pelvis next to the vagina. So when we put that transvaginal probe in, the needle is transversing your vaginal wall and going straight into the ovary to get those follicles. So we go through one by one under ultrasound guidance, and we watch the follicles shrink, and the fluid inside goes into a test tube that's given to our embryologist. The embryologist goes through those test tubes and collects the fluid and collects the eggs. So while your doctor is doing the egg freezing, they're actually saying those numbers to us as we go. So we're going through and aspirating all the follicles under the ultrasound, and our embryologist is in the room with us counting as we hand them the tubes. So the process probably takes most of us about 20 minutes on average. So it is under anesthesia, but it's not a major surgery on your tummy. Like I said, everything is from below through the vagina. The risk of anything, like as far as bleeding, damage to organs, infection with an egg retrieval is less than 1%. So a very uncomplicated, low risk procedure. Once you have the procedure done, you wake up and you're done. So egg freezing, the process, mostly the first 2 weeks, you're monitoring, seeing how the follicles are growing, making sure they get to the right size, triggering you, going for the procedure. And once you wake up from the procedure, you will know your number of eggs and you're done. Your cycle will come in the next week or two and reset from there, and you're completely finished. As someone who's done egg freezing, I remember waking up and feeling relieved at that time, like, oh, it's done. I'm finished. I don't have to think about it anymore. It's an insurance policy as a backup plan, and it can be very invigorating. I know I did it at the same time with my cousin. I had to convince her to do it, an engaged woman to consider it. But I remember we both woke up thinking, oh, I'm just glad it's over. It's an insurance policy. So we will talk to you more about the process itself when the time comes, but just to give you an overview, I always tell patients it's about 2 weeks of your life, 2 weeks of monitoring in the office, the egg retrieval at the end of the 2 weeks, and you're finished. So we want to find that window for you. All right. And I'll answer more questions about that a little bit later if anybody has any questions. So storage. So the data supports there's no difference in survival, fertilization, embryo quality between the live birth rates that eggs are frozen and women who did fresh. So whether you thaw your eggs immediately or a few years later or decades later, the vitrification process is pretty excellent. We know we can freeze eggs for decades at this point. I think we're going to get to the point where with vitrification, it's not only for eggs, sperm, but it's also for embryos. We have patients who may have eggs and embryos outliving them. So you may have eggs and embryos frozen and they may survive longer than you. So we may have to face that as a field and what happens to the disposition after someone dies. Usually when you freeze eggs or embryos with us, you sign a form of what you want to happen to those eggs or embryos. We're not quick to discard eggs and embryos for patients, even if you make a decision. We're always double checking and triple checking before anything happens. So does it matter where you freeze your eggs? I think that's number one. I mean, even with me, when I froze my eggs, I think my first thought was, does this clinic know what they're doing? I think that's most important. A lot of clinics out there will say they freeze eggs, but you really want to have a reputable clinic. As you can see, vitrification was introduced 2007, 2008, maybe 2009 for some clinics. Our clinic has been doing it a while, like 2008, 2007. And some of the longest practices that have been doing it around the same time. So the experience of your fertility center is very important. I would be very frank, a conversation about how long have you been egg freezing? What are your success rates? And when you ask about success rates, different clinics may propose it in a different way. But I think ideally you want to make sure that they can freeze eggs, and their egg freezing process may be very similar to their fresh process or women who are going through IVF. So clinic-specific success rates should be discussed at that consultation. There have been some clinics in the past that freeze eggs that may not be as experienced. So you want to ask about their technology. Are you using slow freezing? Are you doing vitrification? What do you recommend as far as the number of eggs I should freeze in order to have a pregnancy? So everybody has their different threshold. There was a study out of Shady Grove, it was 2016. So they actually specified number of eggs based off their patient population. So they would say if you were if you were less than 38, they recommended 15 to 20 eggs to give you an 80% chance of live birth. And then if you were 38 to 40, they said 25 to 30 eggs to give you a chance of a live birth. So that was their specific numbers, and they've been doing egg freezing for some time as well. Our practice has been doing it a long time. We recommend, we see high success rates with frozen fresh eggs. We correspond with our IVF success, which we report nationally every year to the CDC and START. That's important too. Talk to your clinic and making sure they're reporting their success rates publicly. And this is something you can look up about your clinic. You can go to cdc.org, put in your zip code, and see what IVF centers are near you and look at their success rates. So like I said, we've been freezing eggs a long time. We're one of the few practices in the country that have our own egg bank. So we have women who are doing planned oocyte cryopreservation, formerly known as elective egg freezing. But we also have women who are donating eggs. So women who are donating eggs are basically allowing for women who did not have that opportunity to freeze their eggs to use donated eggs to get pregnant. So we have our own egg bank. Just like a sperm bank, we have our own egg bank, and we've been doing it a long time. So we know how to freeze eggs. That's what's important. So when you're going through this process, you want to feel comfortable that the clinic that you're going to knows what they're doing when it comes to freezing eggs, because you don't want to come back in a few years and find out all that time and money was spent and you didn't have the outcome you were looking for. So your doctor will carefully counsel you on what your chances are of live birth based off your age and the number of eggs you're able to achieve. So where you freeze eggs is very, very important. Like I said, we're the largest and most experienced in Texas. We're the only egg bank in this part of the country, and we've had established stellar success rates for many years with vitrification and egg freezing. So is there an alternative? This is a great question. So whenever a woman comes to see me about egg freezing, I always talk about, egg freezing. I always ask, how important is it to you to have a genetic child? I think having a family can mean a lot of things. It doesn't necessarily mean the baby comes from your DNA. So I talk to women, if that's really important to you to try to have that opportunity, then you can consider egg freezing. Now, for some patients, they're thinking, it's important for me to have that. So we'll talk about that option. The other option we can consider for patients is embryo freezing. So for the women who are a little bit older, where we're worried about their egg freezing process not going as well, they can take it a step further and fertilize those eggs. And by taking it a step further, that means that they may either be committing to using a known donor, someone they know, or using a sperm bank to get sperm and fertilizing their eggs. The younger you are, the more high quality eggs we have, the less likely those eggs will lead to a genetically abnormal embryo, where an embryo that may have like an extra chromosome or a missing chromosome, such as like Down syndrome. There are studies that show that when we get to 38, if you were to fertilize the eggs of women at 38, 50% will be genetically normal and 50% of the embryos that result are abnormal. So you have a 50-50 chance. For those women who are in that age group or older, they may want to actually consider fertilizing the eggs, letting them grow to embryos, and testing the embryos to find out which of those embryos are healthy. So I'd like to bring up the embryo option for the women 38 and up, 40 and up especially, because it gives them the opportunity to know what they have in storage is a healthy embryo. A lot of unknowns are there if you decide to freeze only eggs after 40. You just have to be prepared for the fact that usually 1 out of every 3 embryos is genetically normal. So I think if you think about preparing for a certain number of eggs to accommodate that, or go the next step and have embryos that are tested, I think it's an important conversation to have with your doctor. So embryos are an option. And when I bring up the embryo option, I also talk to patients, how badly do you want to conceive? I mean, is this something that you want to do whether you have a partner or not? So if a patient says, yes, I think embryo is a good option. If they say no, then we'll stick with eggs, because they're not going to use it unless they have a partner that they're motivated to do it with. So besides the IVF stuff we talked about, patients consider donor eggs. So I'll bring that up as well. If you're not that interested in a genetic child in the future, there's always going to be donor egg as an option. So I tell patients if egg freezing is not right for you or not something you're interested in, you will always have an opportunity for donor eggs. So that's always there. Frozen eggs in our practice are readily available for donation, and you can conceive that way. So it's an important conversation to assess how badly do I want a genetic child? And will I consider conceiving on my own without a partner, or would I only conceive with a partner? So those are good questions. We'll also talk to patients about adoption as well, and expanding their families in different ways.